Hey, welcome everyone to the Careers in Army Medicine podcast. Today we have a very special guest, COL Johannigman from San Antonio. So what we're going to do is we're going to go ahead and let Sergeant Fitzwater take this over.
We got a red dot here. Sergeant First Class Todd Fitzwater with the Cleveland Medical Recruiting Station, and I'm joined by First Sergeant Justin Waynick of the Columbus Medical Recruiting Company and Staff Sergeant Michael Sharps of the Akron Medical Recruiting Station. And we are extremely privileged today to have world-renowned trauma surgeon Dr. Jay Johannigman with us today. Dr. Jay, you have been served in the military since 1990, and you're currently a colonel in the United States Army Reserve. You completed combat deployments to Iraq, Afghanistan, I want to say about 7 of those, and received multiple commendations for your outstanding life-saving work and all that. And sir, we're very privileged to have you with us and join us today. And how are you doing today, sir?
Oh, it's great. It's great to be with all of you guys, and it's a real privilege to be on the podcast with you today. And you're too kind. I am just a general surgeon, but I have certainly been privileged to have a long career, and being a military surgeon has been a big part of it, which is why I'm kind of glad to be on here today and share some of those thoughts. I've had a spectacular opportunity with a long career both in the civilian and the military side, so I was anxious to share some of those thoughts today.
Yeah, absolutely. And again, we're privileged to have you with us, sir. I would like to start off by asking you, what is one amazing story that you have? And I know you have several, but what is one that really stands out to you that you could share with us?
Well, I'll kind of bookend it. I'm going to end with a story we talked about before the roll. But on my first deployment, so you're right. I got into military medicine because I had the opportunity to go to medical school through something called HPSP, Health Profession Scholarship Program. I had built up a lot of debt going to college, and the military scholarship program got me through medical school. Went through general surgery training, trauma and critical care, and all as a reservist in the inactive reserves. And then actually my first years of duty were at Wilford Hall, and I actually entered as an Air Force reservist. Transitioned back into the civilian world in the mid-90s, and then in 2001, obviously our world changed. In 2003, I had my first deployment with the Air Force in a small, austere surgical facility. We had one operating room. We were a EMEDS 25, which is essentially about like a forward surgical team. We were in a place called Talil, Iraq, and we saw a modest number of casualties, but the one that changed my life was we were working on a Saturday, got a call from the gate that an ambulance from the nearby town was there, and they had a young child in the back. And that child had been injured about 10 days earlier by picking up an anti-personnel device out of curiosity, and it exploded, killing his brother and grievously wounding him. He lost an eye, lost an arm, and had an open abdomen. To make a long story short, over the next approximately 4 weeks, we would operate on this young 9-year-old child some 12 times in a tent with military medicine and the colleagues and the tools we had been taught. And we were able to stabilize him, that young man, through some real miracles of both medicine and military service. Actually would eventually be airlifted by an Air Force CCAT team to Germany, and then in an air refueled flight would make it all the way out to California, where a pediatric hospital had volunteered to take him in. That was in 2003, and a little bit earlier this year, I was privileged to see the graduation video of that young man when he graduated from his college equivalent, and we still stay in touch. And the American College of Surgeons actually made him a highlight because he was the first combatant or child or injured person in the theater to actually have a wound vac applied, and the young man's doing very, very well. So that was a journey and an odyssey I'll never forget. I'm so proud of the team we took care of him. That was my first deployment. As you mentioned, I have had the opportunity, I've deployed to Iraq on a number of occasions, in Afghanistan, in the Air Force, being a surgeon in a sea catter. And then my career continued in the civilian world. I worked primarily at the University of Cincinnati, and about a year and a half ago, I made a decision to spend the last part of my career full-time doing the thing that I really enjoy the most. So I transitioned back here to Brooke Army Medical Center in San Antonio, where I'm working in the contractor status for the critical care and trauma surgery service. The bookend story was about 4.5 months ago. We received a soldier who had an incredible story where Army medicine has come in the war years. This was an Army Ranger who was on a mission when they took some indirect fire, but one of the fragments from the mortar round actually hit him, striking his hand grenade that was on his web belt, detonating the hand grenade. Obviously a devastating injury right then and there. He was with a squad, he is a Ranger, and was with his Ranger squad, the element of about 15 strong. Over the past 5 to 7 years, the life-saving opportunities provided by whole blood transfusions have become increasingly apparent, and Army medicine, particularly Ranger medicine and the Committee on Tactical Combat Casualty Care, has pushed the envelope such that in today's operational environment, the Ranger medics will be carrying whole blood with them, or have the opportunity to transfuse whole blood. So this Army Ranger, when the grenade detonated, it took off a large portion of his hip and resulted in a traumatic amputation and the loss of the same side arm. The Ranger medics were on top of him immediately. They applied tourniquets as they should, and they began applying compression dressings to the pelvis area. But most importantly, that medic who attended to him was carrying 2 units of whole blood in a Ranger ready box, which kept the blood cold. So he, in addition to providing life-saving hemorrhage control, immediately began transfusing 2 units of blood. While a medevac was being called for, the casualty responded to the 2 units of whole blood. Blood pressure improved, his pulse came down. But the story is just beginning, because after those 2 units of whole blood, because of the tactical situation, rotary wing evacuation was still about 45 minutes to an hour away. Unbelievably, but it's still hard for me to realize, but having been on the committees that helped look at all this, we realized that whole blood is life-saving, and if we don't have it already harvested, we can harvest it from other members of that Ranger unit. So the Rangers actually type themselves, and the Rangers who are O, either positive or negative, are identified. They know who they are. And in a situation such as this, when more whole blood was necessary, they actually carry transfusion bags in their rucksacks. So the medic called for 2 of the members of the squadron who were known to be O donors to go ahead and lay down, and go ahead. The medics harvested a unit of blood from 2 of the Rangers in that element. So in addition to 2 units of whole blood already carried in a ready box, 2 additional units of warm, fresh whole blood in the middle of the night, in the dark, were harvested and given to that casualty, which provided enough stabilization that the casualty was evacuated by rotary wing to what's called a forward surgical team. The forward surgical team received the casualty at about 90 minutes from wounding. Forward surgical team is staffed by a surgeon and an orthopedic surgeon. They have some operative capabilities, but their primary role was to do exactly what they did that night, which was to further stabilize. They addressed the large pelvic wound, got a degree of hemostasis, continued to transfuse with whole blood as they had the capability at their role 2 out there. And then they were prepared to immediately evacuate that casualty to the larger role 3 over at Bagram Air Base. So they had the casualty for approximately 1.5 hours to 2 hours while they're stabilizing, transfusing, trying to get surgical hemostasis. And then the casualties moved to Bagram. Bagram is what we call a Role 3, but really the equivalent of a civilian Role 1. Casualty arrived there probably at about the 4-hour mark after wounding and goes straight to the operating room, where over the course of about a 3.5-hour operation, he gets a definitive amputation, the pelvis is further stabilized, the arm stabilized. He received about an additional 40 units of blood in that operation and comes out now with a real fighting chance for survival. Concomitantly, in the meantime, while this is going on, it's understood how sick this casualty is going to be, and the likelihood that he's going to need advanced aggressive en route care was recognized. So the ECLS, or the ECMO team from Brooke Army Medical Center right here, led by Colonel Phil Mason, was launched at about the 6-hour mark and begins the process of flying over there to meet the casualty en route. So they're aerial refueled, and they, I honestly don't remember all the details. I don't know if they transited through long, but they are patients at a hour. Bagram had continued to stabilize the patient. The ECMO team actually is over there now. And what's also amazing to me in my long history of practice of trauma medicine, you know, the whole blood transfusion has really dramatically changed the impact of these kind of resuscitations on the lungs. Clearly, 20 years ago, this patient would have had a very bad case of ARDS after this kind of trauma. But with all the whole blood transfusion and a very limited amount of crystalloid, his lungs actually were doing reasonably well. The team had gone over anticipating he might actually require ECMO. He did not, but he did require continuous renal replacement therapy. This is all done by the ECMO team. They really do both ECMO and any form of extracorporeal life support. So Bagram had the opportunity. Bagram does have CRT. They placed him on CRT, and the casualty was picked up by Colonel Mason and his team. CRT was continued. I do know that from Bagram back all the way to Brooke Army Medical Center, that was one continuous flight, 2 refuelings in flight, and that casualty actually gets back to Brooke Army Medical Center somewhere about the 36 to 40-hour mark. And that casualty was cared for at the ISR and the burn center, underwent multiple debridements, but it survived and is actually now in the process of being transitioned into rehab. He'll return to the Center for the Intrepid here at Brooke Army Medical Center, where he'll meet the most sophisticated rehab team that there is, and his prosthetic for his lower extremity will be developed as for his upper arm. I spoke to the team taking care of that troop. He's been discharged a while back and is waiting to have sufficient maturation of his wounds that he'll actually end up at the CFI. So those are the kind of incredible stories. Clearly this would not have been a case that the wonderful civilian trauma centers I've been exposed to, with all their expertise, probably would not have survived. But the lessons learned, the use of whole blood, which has really been pushed quite aggressively and appropriately by the military. And interestingly, being somewhat of a student of history, it really isn't an advance. It's really just a return to what we did first in World War I, then in World War II, then in Korea, and in Vietnam. We are now really pushing whole blood.
2 incredible stories, sir. Like you said, bookend. The selflessness and the professionalism and the degree of skill involved in those 2 stories is just outstanding. First Sergeant Wainick, you have been deployed as well, and you were in the Baghdad ER during your time. Can you tell us a little bit about that? And then I know you have a question for Colonel Johannigman.
Yeah, sir, I really appreciate those questions. It definitely, brings me back from during my time on deployment. Like Sergeant Fitzwater had said, I've deployed a couple of times. First time was as a line medic, is what we call line medic. So the guy that's on the ground with with the infantry. Basically, job was to stabilize them, our casualties, the best that we could, for medevac to be able to come pick them up and take them to the next echelon of care. Then second deployment, I started off as a aviation medic. So I was actually the guy that was picking those casualties up and keeping them stabilized in order to get them to that next echelon and basically get them to the surgeon, to be able to provide those life-saving medical treatments that they needed. And then I also spent some time during that deployment in the Baghdad ER. And it was there that I truly understood, when we talk about the need for physicians within the Army. During that deployment, we were the busiest trauma hospital in the world at the time. And we had 3 ER docs that was on staff during that deployment. So they were very busy, just between different, mass casualty situations and things like that. Very busy, but the amount of experience and the amount of lives that those 3 doctors saved is a countless number. I wouldn't be able to even keep up with that number. And so one of the things that when the Army asked me to come out to recruiting and help find new medical professionals to join the Army, it's something that I took very, very seriously, because I've been in a situation where we didn't necessarily have the amount of doctors that we needed at the time to be able to do the things that we needed to do. And it was I was asked to do some of those treatments. So one of the things that I tell a lot about to a physician that might be interested in joining the Army is they ask me what it's like being an Army doctor. Obviously, I've never been one, so I can't really tell them. But I do tell them that it's an opportunity to be able to practice pure medicine. And what I mean by that is in the Army medicine, we provide the treatment that is needed when and where it needs to be done. So with your experience, having served in the military as a physician for so long, and also on the civilian side, maybe you could share a little bit with us about what you think maybe the biggest difference is between practicing medicine within the Army and then practicing medicine on the civilian side.
Yeah, thanks, Justin. I'll tell you what, it is really great being here, because I get to be around the young residents, the military residents, who will be the next ones out there. But I tell them what I would tell, and I had the opportunity of working with you recruiters to talk about people making that jump. Deployments are the best of everything, and they're the worst of everything. It is a challenge. I guess, over 7 of them, and I think I've got 1 or 2 left in me. It's not all fun and games. There's some really bad times. There's some really boring times. But if you want to be in a place where you're really practicing medicine and you have a team that has one common cause, nobody likes being in the middle of a desert in a tent, eating horrible food. But when that casualty hits that gurney, there's not a single question about what we're there for. There is not anyone who won't do anything to make sure we do everything right for that casualty, be that one of our own, or be that a civilian, or be that a child. It's also really kind of cool. And I'm obviously a lot older, and as I teach the young residents, I get to be a general surgeon, and I go back and I have to use a stethoscope, and I have to use my hands and my head. I don't have a CAT scanner. I don't have an MRI. I have to do those things I was taught to do. So it is pure, and it can be terrifying, but I've left every one of those with a sense of satisfaction. I also leave every deployment with things that I try to take back to the civilian centers I've worked at and change, so for instance, in the mid-2000s, I saw point-of-care testing, I saw tags, I saw tourniquets, I saw whole blood. I'll never forget the first time I saw whole blood. Now, it took 10 years to be able to translate that to the civilian world, but it's fascinating. Those of you listening, you may or may not be aware, here in the city of San Antonio, because of military medicine's presence, we have a great presence with Brooke Army Medical Center, Wilford Hall, and the Institute of Surgical Research. In this city, whole blood's carried on the EMS rigs, it's carried in the helicopters, and we are transfusing at our trauma center. We'll see whole blood almost daily coming in from the pre-hospital environment. We have whole blood now on our massive transfusion protocol. It's really dramatically changed the way I can take care of patients. So yeah, it is. I remember a young surgeon I was deployed with coming to me and griping, saying, "This isn't the standard of care. I don't know how to practice." And I walked him to the edge of the tent, and we opened up the flap and looked at the desert, and I said, "Well, this isn't the standard of care either, but it is medicine. It's very good medicine, very effective medicine, and it's amazing what you can do out there with a few simple skill sets and these life-changing advances, which again really are returning to what we've learned a long time ago. It's unfortunately true that the study of shock and trauma is always advanced during war. It's just so important we don't forget those lessons. And that's what's fun about being down here, is making sure that the next generation is going to remember those.
Yeah, it's got to be interesting in your position, sir, you know, with your years of experience, to be able to work with those young Army residents at this point. It's got to be pretty neat to be able to give back in that capacity, would you say?
Oh, it's the very best. It's the very best. And yeah, that's, I think that's what really has reawakened me and has just been a real joy for the last year.
And it's interesting too, sir, because we find that often in what we're doing in Army medicine, in recruiting, the recruiting aspect is that we have the younger physicians that come out that want to get involved and are looking to pay back their student loans. And then we also have, you know, some of our older providers that want to come in and they just want to be able to give back at that time and share the knowledge and experiences that they've had over the years, and then they want to join our team. So it's really where you're at in life at the time that determines which path you're going to take and how you come to us in Army medicine. Sergeant Sharps, I know you have a few questions for Colonel Johannigman.
Yeah, sir. So I was also one of those ground medics, same as First Sergeant Wainick. And actually we had an experience when I was out in Hawaii where one of the medics from our sister unit was in a motorcycle versus car incident. And being a medic, as soon as that happened, he knew to put a tourniquet on himself. And when the civil authorities showed up, so the EMS, they said that tourniquets were not part of their protocol and forced him to remove that tourniquet. Well, didn't force him. He was fighting them off. And he said until he lost consciousness, then they removed the tourniquet after he lost consciousness. He did end up losing his leg. But with that, as every junior medic knows, tourniquet first. If you see bright red blood, go ahead and put it on. And that's even getting pushed down to everybody else. So it doesn't matter if you're a cook, you're a mechanic, you're one of the door kickers. Everybody knows that in the military. What, besides whole blood, we've already covered that kind of, what else have you seen has been the biggest medical advancement that has come from the military and transferred to the civilian sector?
Yeah, you know, I think you go back to the Boston Marathon bombing, and we learned, so there's a saying that all of you are familiar with, these lessons are lessons written in blood. And the Committee on Tactical Combat Casualty Care, early in 2004 and 5, we're already starting to track another one of those lessons we have to relearn. Tourniquets have been in the military armamentarium since the Civil War. For some reason, we decided they were not, that they were dangerous, but clearly that's not the case. Colonel Holcomb in the Institute of Surgical Research, Dr. Craig, Colonel Craig looked at our early results with tourniquets. Clearly they saved lives. So as you all know, we're out of uniform in theater if we don't have the tourniquet tab visible on our blouses or on our ACU pant leg. And you're right. I can't remember a time in my last 12 years of deploying where I ever saw a casualty come in a military setting where the tourniquet was applied. But quite honestly, in the civilian world, there's still times I see EMS bring people in. Now, those are getting fewer and fewer. But you go back to the Boston Marathon bombing, I had the opportunity to talk to a couple of Boston firefighters. And you can actually, if you go out in the press and look for the pictures, you'll see a couple of civilian patients being wheeled around or evacuated with traumatic amputations and homemade tourniquets, cravats or handkerchiefs, and no effective tourniquets. Well, we hadn't penetrated. The Boston, interestingly enough, the Boston EMS did have tourniquets, but they were all in their EMS rigs, and the rigs were parked a couple of miles away from the final, the finish line. So when the bomb went off, they weren't immediately in their pockets. So that's been one of the other translational lessons. You know, we have tranexamic acid. We have the use of whole blood, as we've talked about a lot. We have laboratory-wise TAG testing and the management of coagulopathy. All those lessons learned, shared with our civilian colleagues. It's been a really, having a foot in both worlds, it's been really great to see the support, the interplay. The professional societies on our surgical world have been amazingly supportive of the mission, of the science, making sure we forward those lessons learned, validating, vetting, correcting, and helping us bring them forward.
Awesome. Sounds good, sir. One of the things that we've kind of done in the past with a few of these other interviews is I have a duck of random questions. So kind of throwing a curveball out there, not medically related one bit, but it's just kind of to show that even though we put the uniform on, we're people too. So one of the things I do want to ask you is, what's something you like that most people don't?
Going uphill, big long hills on a bicycle.
Sounds good, sir. Thank you.
Sir, you must be a fan of the mountain stages in the Tour de France then.
Actually, I am, and one of my life memories, I've had a group of dear friends. We've cycled for the last 30 years or so, and every year, instead of going away and golfing as guys, about 8 of us, we would pick a place and go ride our bicycles. And about 10 years ago, we went and hit the Alpe d'Huez, famous, and all the tours, the big climbs over in France, and it was a lifetime. But yeah.
Well, I can appreciate that as a fan of the Tour de France and Alpe d'Huez, especially. Was that 22 turns heading up that mountain?
You got it exactly right.
Yes.
You know, before I would like those who are interested in Army or military medicine, obviously, this is a wonderful program by our Army recruiters, but military medicine, you know, honestly, having worn 2 uniforms, I don't think I'll be joining the Navy before I retire, but military medicine's a real privilege. Here in my office in front of me, I don't have the time to spin the cameras, but over on this wall is a picture of a Korean MASH unit. I didn't know my father well, but my father was an Army forward artillery officer. And he left when I was a young man before I heard his military stories. But interestingly, about 12 years ago, I met a retired Army artillery officer who was with my dad. And it turns out that they had both gone through ROTC together, and my dad was wounded when they were bugging out their unit. And my dad was responsible for blowing up the ammo dump, but got burnt in the process. This guy put my dad out, smothered him out, and waited with him until an HH-13 came along, that iconic little bubble helicopter, and delivered him to a tent hospital that sits and looks very much like the one that's sitting over there. And interestingly enough, right next to it is a picture of our little forward surgical team in Toledo. The configuration of the tent is identical. The only difference is they were Army green in Korea, and they were kind of a buff khaki in Iraq, but we set them up exactly the same way. I wouldn't be here had there not been Army physicians in Korea Long after I'm gone, perhaps somebody will carry on and look at a legacy of somebody we brought home. It is a privilege unparalleled. I certainly have gotten much more from my experiences in the military than the military's ever asked for me. So as I look back when I step down and retire, each and every one of those 7 deployments and the experiences and the people that I was privileged to work with, those will be the memories I carry with me. And it's been a privilege to work with military medics and privilege working with you guys today. I do want to, your audience, the guys will have my email and my telephone cell number available at any time. If you have questions, I really enjoy talking to you. That's the trauma pager. Talking to you guys, I will try to give you it straight. I will tell you the good things and the bad things. But for me, obviously, the good things have been more than enough. My mementos sitting over my shoulder right behind me, as you can see. So, barring any reattacks or further questions.
Hey, everyone. As you saw, the trauma page went off, so we actually had to go ahead and let him get going. So if you do have any questions, like you said, he is available, but in his best interest, I don't want to actually publish his email address out there. So if you do want to get a hold of him, if you're an applicant, if you're interested in Army medicine, anything like that, go ahead and either reach out to us here on YouTube or visit one of our other social media platforms. We have people available to talk to you at all times, so that way we can get your questions answered. And if it's one of those things where we can't answer it, we are glad to put you in contact with somebody like Colonel Jay that can actually answer those questions from firsthand experience. But thank you very much. Go ahead and like, subscribe, and leave us a comment. Thank you.